Good evening, and thank you all for attending this third annual Judith A. Shinogle Memorial Fund Award Lecture. I'm Don Norris, Director of the UMBC School of Public Policy, and also Director of the Maryland Institute for Policy Analysis and Research, or MIPAR, here at UMBC. This evening's program will proceed as follows. First, I will say a few words by way of introduction. Then I will turn the program over to my colleague, David Saltkeeper, who will say a few words about Judy, and will then introduce our speaker and recipient of the third Judith A. Shinogle Memorial Fund Award, Mike Abrams. Mike will then give a talk. His talk is entitled Mental Health Policy and FDA Warnings. FDA Warnings sounds very serious. I've also asked Mike to talk briefly about Judy and how she influenced him. After the talk, I'm sure Mike will be pleased to take questions. Then we recess to the rear of the room where there will be food and beverage, including adult beverages, which I see that some of you have already wisely chosen to take part of. Sadly, I'm talking, so I can't do that because talking and drinking just doesn't work for me. Moving on now. Judy Shinogle received her BSc degree in pharmacy from the University of Kansas and an MSc in health policy and management from the Harvard School of Public Health, and a PhD in public health economics from Johns Hopkins University, where David was her mentor. Judy came to MIPAR in August of 2008 from a position at the University of Maryland, College Park. Prior to that, she had held positions at the University of South Carolina, the American Pharmaceutical Association, the Congressional Budget Office, and RTI International, among others. At MIPAR, Judy held the position of Senior Research Scientist, and her work involved a number of projects, including the statewide examination of gambling prevalence in Maryland, funded by the Maryland State Department of Health and Mental Hygiene, which was, in fact, required to fund it by the General Assembly when the General Assembly, in its infinite wisdom, decided to let the people of the state of Maryland decide whether they wanted 12 or 14 casinos. I'm not sure quite what the last number of casinos is, but we do have a surfeit of gambling in this state. And I worked with Judy on that project. It was a really fun and interesting project. And what it told us was that a lot of people in Maryland gamble, hence the overwhelming support for having gambling in the state. And that a fraction, a non-trivial fraction of people were either problem or what's the word I'm looking for? Pathological. Thank you, Bob. Pathological gamblers, for which there are now programs that are funded by gambling revenue to help them as they become more problematic and more pathological, I suppose. She also worked on an analysis of the introduction of video lottery terminals in Maryland with myself and with Bob Carpenter. She worked on an exploration of employee assistant programs, treatment of intimate partner violence funded by the Robert Wood Johnson Foundation, and an examination of individual, family, and school factors in Latino children's weight changes. Judy periodically taught courses in the School of Public Policy and was also actively pursuing external funding for her research endeavors, including funding from prestigious federal foundations. But beyond that, Judy was our friend, our colleague, somebody that we had a lot of fun with, and somebody that we miss terribly. Tragically, Judy lost her life on May 20th of 2012 when a vehicle crossed the median on the Baltimore-Washington Parkway and crashed head-on into her car, killing her and one of her two beloved dogs. Those of us who knew Judy were then and today, to this day, remain deeply saddened by her death. In an irony of fate, shortly after her death, we learned that two proposals that she had submitted for external funding had been accepted. They were from the National Institutes of Health, a project entitled Multiple Impact Effectiveness of a State-Supported Employment Policy Initiative. She was the PI on it, and the grant was for $661,000. From the Agency for Healthcare Research and Quality, a project entitled Impact of Employment Interventions for Persons with Serious Mental Illness. Judy was also PI on this, and the grant award was for $475,000. David has taken over these projects, and with a team that incidentally includes Mike, among others. Did I see Brent here? And Brent. they are working on the project, and they are completing the research that Judy got funded. In the fall of 2012, Judy's family generously established the Judith A. Shinogle Memorial Fund. The purpose of the fund is to help support doctoral students in the School of Public Policy who are conducting high-quality research in one of the following areas: the economics of health, mental health, or pharmaceutical policies and practices. 3 areas of Judy's interest. Mike Abrams, as I previously mentioned, is the fund's 3rd award recipient. Once again, I want to thank the Shinogle family, Paul and Louise, and their children for their generosity in setting up this award. I also want to recognize Jim McCarthy. Jim, where are you?
I'm in the back.
Jim is in the back. Hi, Jim. Jim is Judy's significant other, and he is here tonight to remember Judy along with the rest of us. Unfortunately, none of the rest of Judy's family could attend tonight, and that's why we are recording this so that they can view it at their leisure. I'm not going to shamelessly promote here and get down on my knees and beg you all for money. That would be unseemly, although, you know, if it worked, I'd probably do it. I'm learning from Freeman, who I think can shake that tree as well as anybody else. I've seen him in action. But I'm not going to be a shameless promoter and solicit contributions to the Shinogle Fund, even though I've probably already done that a little bit. But if you might be interested in giving, you can see either me or Ann Rowland, Ann in the back, and we will talk to you about how you might go about doing that. Speaking of Ann, I want to take this opportunity to thank her for taking care of all of the arrangements for this evening. The food, the drink, the setup, the logistics, the whole thing. Let's give Ann a hand. She spent many, many hours yesterday cooking and preparing food. So let me now ask David Saltkeeper to come forward and say a few words about Judy and to introduce Mike Abrams. David?
Well, as Don suggested, this is always been a bit of a bittersweet experience for us. Judy was such a generous colleague, sharer of ideas. Interacting with her just sort of helped make you a little more energetic than I wanted to be. And as you might have gotten a sense from Don, she had a wide range of interests. This way? Better?
Yeah.
Okay. Let's see. Well, she had a wide range of interests, and she was really very active in as almost sort of an outreach ambassador for us, making presentations at conferences, obviously participating in publications, and in addition, although her primary responsibility was to the MyPAR research program, she also made some very important contributions to our teaching program, and had been involved in developing some very useful courses that I think are the development of which slowed down precipitously, obviously, with Judy's passing, but remain things that we, are thinking about in terms of how to move the curriculum even further ahead. I guess we should feel fortunate that we had the benefit of Judy's interactions and talents, and the fact that she also managed to inspire a number of other more junior individuals, students to come along and follow in her footsteps, including our primary speaker today, Michael. Michael, I think, shares some of Judy's endearing qualities, such as being very energetic, being interested in many things. Of course, when you're a doctoral student trying to write your thesis, it's better not to be interested in too many things. But as Michael's advisor, I try to remind him of that. Michael has had an interesting career before coming to UMBC, starting back with, I guess what you would call hard science education, essentially at Berkeley, UCal Berkeley, and then going through the master's program at the School of Public Health at Hopkins, and then moving on to active work at the Hilltop Institute, and along with that, entering our our program of studies. Michael, as you will hear, has worked actively with myself and other folks in the department on several projects that Judy was instrumental in initiating, and I think serves his discussion of that serves to remind us of the depth of the impact that Judy actually made on our research program as well as our teaching program. So without further ado, Michael.
Thanks. Can you hear me okay? So it's really nice to see everybody. Welcome here to UMBC. Just right over there is the School of Public Policy. You can see Dr. Norris's office there in the corner. And just around past the elevator is where Judy had her office. And I used to like to stop in there when I was coming and going from the department back to my office at the School of Public Policy and have a little chat with her about a variety of things. I miss Judy and was just really getting to know her and starting to work with her a lot when she passed. So it's my very distinct and special honor to be able to talk to you today about the work that I did with her and also about my own dissertation research, which I think you'll see follows in good part from some of the influences that Judy gave me. I've structured my talk with two parts, essentially. First, I'm going to go through a couple of projects that I did with Judy that were mentioned previously, and nice introductions from Dr. Norris and Dr. Salkever. And then I'm going to spend most of my time talking about my dissertation project, tell you where I'm at with that, and encourage you to give me some feedback as well at the end and ask me some questions about it. So Anne has generously agreed to advance the slides for me. There we go, thanks. So the first project that I want to describe to you that I did with Judy was looking at employment supports for individuals with serious mental illness. And by serious mental illness, what I mean specifically is individuals with schizophrenia and bipolar disorder, spectrum of disorders that are exceedingly severe with regard to mental illnesses, often leading to disability, often being highly correlated with enrollment in Medicaid, program for individuals with low income, and Medicaid and Medicare as well, because the Medicare program is serving large numbers of individuals with disability. Serious functional impairment goes along with that. And part of that impairment means that they are not employed at very high levels. In fact, data that exists on this indicates that they are only working at about, have an employment rate of about 15%. Even as 2/3 of individuals with serious mental illness say that they have employment as a goal, okay? So there's a clear gap in there, and why not? The benefits of working are, you don't have to be an economist to understand that not only are there financial benefits, but there are cultural, self-esteem, social integration benefits that go along with that. And even more vexing regarding this problem is that there are evidence-based approaches to helping individuals with serious mental illness get into the workforce. And yet we still have this large gap. Can we have the next slide, please? So, as Dr. Norris noted, in response to this problem, Judy submitted a proposal to the NIMH, which was funded, ironically, after her death, and her first R01 to be funded. And the purpose of that study was to look at Maryland Medicaid's implementation of evidence-based supported employment. And this was implemented back in 2002, and generally speaking involved financial incentives to providers to deliver such services, and also some training programs as well to get those programs up to speed with fidelity with regard to delivering those services in an evidence-based fashion. So what we did, what we're in the process of doing under David Salkever's leadership now, is taking some administrative source data from three areas. Administrative data records from the Maryland Medicaid program, which is what I principally work with at the Hilltop Institute, and data ranging from 2001 to 2010, so we can span the implementation of that program. Additionally, we obtained data, and this is somewhat novel for us, we obtained data from the Department of Labor and Licensing, so we could look at employment outcomes, earnings, as well as number of hours in the employment workforce for these individuals in this program and other individuals that we'd compare them to. And then finally, we obtained data from the Behavioral Health Administration so that we could look at some clinical outcomes that they collect for individuals who are engaged in the public mental health system. So with those three large data sources, we're addressing the following questions. First, we want to look at just who's using these services, okay? And I'm going to show you a slide in a minute that'll give you some sense of how limited it is right now. We also are looking at earnings, of course, from the DLLR data that we got, functional, various levels of functioning that we can assess using the Behavioral Health Administration that we've obtained. And then we're looking at utilization of Medicaid services, including costs. This is a large effort that I've been involved in, also others on our team, including Brent Gibbons, who I'm pleased to see is here tonight. So with the next slide, I'll give you a little sense of the scope of the type of data that we're looking at. And this is one pie chart. It took quite a large effort of programmers and folks on our research team to compile this together. But what I'm showing you here is a slice from our data set that has something like 1,000 variables across 10 years. So it's a large data set that we're working on now. And what I'm showing you here is expenditure information on our total cohort. So this is 2004 data on individuals who met criteria with SMI, just over 25,000. And it's summarizing for you their expenditures in the Medicaid program, and some Medicare expenditures are summarized here as well. We're talking about $500 million worth of expenditures for these folks, about $20,000 a person. They're a high-cost group. One observation I'll make for you, so we've got lots of work to do on this, but one observation I'll make for you just initially about this is that supported employment, this program, which is the focus of our intervention, takes up only a very small sliver of that pie. It's not using up very many resources. If our research is successful, and our a priori hypotheses are that if this is expanded and more people are put into the workforce, we might be able to collapse some of these other parts of the pie that are less desirable. For example, especially mental health inpatient, who wants to go to a psych unit if that's avoidable. Supported employment strategy is one way we hope that we might be able to affect that kind of change. That's what this research is about. The reason that I'm involved in this research is because of David Salkever and because of Judith Shinogle. Next slide, please. Another problem, this is outside of my comfort zone. This is not a mental health project, but it's an important one, and one that also Judy was involved in initiating. It involves reducing asthma mortality, and particularly in Baltimore City. So let me quickly give you a scope of what that problem is like. In Maryland, there's about just over 800,000 individuals who suffer from asthma. Individuals who suffer from asthma have high rates of hospitalizations and emergency room visits. These are avoidable visits, too. These are crisis visits that are avoidable. They cost a lot of money as well, okay? Asthma also can lead to death. An asthma attack can lead to death. It's a serious ailment. As it turns out as well, from epidemiologic studies, we know that asthma morbidity is concentrated in Baltimore City or in urban environments. And we also know, data that I'm not showing you here, that there's large numbers of Medicaid enrollees. About half of the individuals in Baltimore City with asthma, especially among kids, are in Baltimore City. And there's lots of kids who suffer from asthma morbidity. So there's concentrations in these populations. Next slide, please. So the project that Judy helped us get funding for and conceptualize targets Medicaid children in Baltimore City with asthma, okay? And it does so with a very simple public health approach. It says, okay, let's get consent from families. If they give us consent, let's go into the home and help them remove pathogens from their home that exacerbate asthma. Let's also help them improve the environment in their home so that their asthma is not exacerbated by things like swings in temperature in the home. And also give them some counseling that helps them get to the doctor more and manage their medications. There are medications to control asthma, and then there's medications, rescue medications, and those need to be used differently. That simple intervention is the subject of this grant that we obtained, in part, again, because of Judy's initiative. And it asks the question, does this intervention, which, by the way, is known as the Green and Healthy Homes Initiative here in Baltimore City, is where it's based, and it's being implemented in at least 16 other cities. Does that program yield cost savings to Medicaid and energy savings as well? That's the question that we're addressing. And some secondary outcomes that we're looking at too, which I find interesting and potentially important for mental health services research. How about what's the impact on work days missed by parents? What's the impact on school days missed by kids? Educational outcomes are an important mental health outcome. Okay, so we're doing that using a study that has so far enrolled about 220 families in Baltimore City. This month or next month we should complete that enrollment, and then we'll be moving forward to take a look and see how these individuals do compared to some propensity matched or some matched individuals that we select from the Medicaid program, to see what are the return on investment, if you will, of this important intervention. Again, because of Judy, in part, we got this project and are working on this grant. Next slide, please. Okay, so now let me turn to my dissertation research. Okay, and here's the question that I'm looking at, and then I'm going to try to persuade you that it's a reasonable question, and then show you a bit of data and show you where I'm at. Okay, the question is as follows. I'm looking at trying to explore the extent to which news coverage, okay, newspaper coverage in the mass media, or newspaper or news on the TV or on the radio band, to what extent that impacts the dissemination of warnings on prescription medications and warnings that are issued by the Food and Drug Administration. Okay, so news coverage, how does that impact the dissemination of warnings issued by the Food and Drug Administration on prescription drugs? Okay, so in order to do that, I think there are the next 4 slides, I'm going to try to persuade you that's a reasonable policy question to address. The first thing that I want to persuade you, and I did this to persuade myself as well, was that pharmaceuticals matter in the biomedical enterprise, okay? So I do mental health, a long-time mental health services researcher. Before that I did behavioral genetics and brain imaging, so mental illness is what I'm interested in, what gets me excited. Of course, you don't have to be even an expert in psychiatry to know that in the last 50 or 60 years, there's been a huge advance in psychotropic medications to treat major mental illness, starting with antipsychotics like clozapine to treat psychosis, now used to treat other forms of mental illness like bipolar disorder, and then Prozac coming online in the late 80s, of course, revolutionized the treatment of depression and also used to treat other major mental illnesses, anxiety, et cetera. And then also heavy use and a lot of use of stimulants and other psychotropic used to treat attentional problems, hyperactivity problems in children and adults. This is a big deal. There are people in the room who know more about this than I do, but it's a big deal. Drugs are important, certainly, in treating major mental illness. But they're also important, and I don't think this is a hard sell either, in treating other forms of mental illness. And in fact, there's even econometric analyses that indicate a substantial return on investment in the order of 10 to 1. So what do I mean by that? For every $1 a patient puts into buying their medications, they save $10 in reduced morbidity, mortality, things that, to the extent that we can monetize those things. Drugs work, they make people better, they make people healthy. There's a lot of good things about drugs, even as I don't want to discount controversy that comes with use of them as well. We spend in this country something on the order of $200 to $300 billion on medications for the direct procurement of medications, okay? That doesn't include the transactions that lead up to that, the doctors telling you what prescription you need, the monitoring of that prescription. So of the $2 to $3 trillion we spend on healthcare, probably now we're pushing $3 trillion, a substantial portion of that, well above 10%, is being spent on pharmaceutical dispersion and monitoring. Okay, it's a big part of medicine. If that isn't persuasive enough for you, there was a recent, and you may have even seen in the news, publication in JAMA that summarized the importance of drugs nicely. And it reported through looking at large administrative data that 60% of adults, if you ask them in the last 30 days, used a prescription drug. And if that isn't persuasive enough for you, somewhere between 8 and 15% of adults use 5 or more medicines at one time. Okay? Next slide, please. So drugs are important. Next thing I had to persuade myself of was that the FDA matters. Okay? There's a rich literature on the reputation and power of the Food and Drug Administration. They are the principal gatekeeper of marketing drugs in this country. Okay? Not a very liberal country, a free market country, and yet we have a system where if you want to sell a medicine here, you first must get it approved by the FDA. Okay? They're the gatekeeper. They have veto power over it since 1962, at least, have had the veto power over that. This bullet is just a very abbreviated summary of the drug development pipeline. So once you get your pivotal clinical trials, which involve only about 3,000 to 5,000 individuals, and you demonstrate that your drug works and is safe and effective in that population of 3,000 to 5,000, bingo, you can start selling it. Okay? That's what they refer to as phase 1 through 3 development of a drug. Post-marketing surveillance, relatively novel concept now. That's what some people refer to as phase 4. That's the focus of my dissertation because, as you may have discerned already from the way I've described this, the drug approval process is imperfect. Some drugs get through that cause problems. And in fact, when I was developing my PhD ideas, 2 decisions influenced my thinking that this would be an interesting problem to tackle. One was that the COX-2 inhibitor pain relievers, Vioxx and Bextra, were pulled from the market by the FDA because in post-marketing surveillance data, it was determined that it led to heart attacks. It was killing people. Okay? Still in some litigation today, that drug. And a second warning, which you can imagine I would have attended to, was that antidepressants used in kids was determined to increase their risk for suicidal ideations, thoughts of suicide, perhaps even attempting suicide. Okay? Those 2 warnings jointly, and I'm quoting the political scientist Weisert and Weisert, embarrassed the FDA. Charles Grassley had hearings. It changed the FDA's attitude on this through external pressure and political pressure. And when the FDAA was passed in 2007, there were provisions that were put in there specifically to address phase 4, and for the FDA to, really for the first time, to start to aggressively address phase 4. Next slide, please. And one of the ways that they did this, which I took interest in and which became my focus here in this research, was they issue warnings. Okay? So the FDA, once it approves a drug, is arguably not very enthusiastic about withdrawing it from the market. It does sometimes happen, like with Vioxx and Bextra. But typically what they do is they'll issue warnings. And what I'm showing you here are 2 time series that demonstrate, just in a very simple way, what happens before and after a warning like this is issued. So the top slide here is showing you, and really all you need to attend to is that the arrows here are the warning points, in this case for SSRIs in children. And the dotted lines are where use of the drug was expected to go, in this case in boys and girls. And you can see a break in the solid line, which is where the drug use actually went. So this is a simple way for me to convey to you, and in the way that I persuaded myself, that these warnings have impact. Okay? On the bottom, we're looking at diabetes medication. The warning in this case was for cardiovascular events, heart attacks related to that drug. Okay? So warnings matter. Next slide, please. Finally, I had to persuade myself that news matters, okay? Because the transaction between a doctor and patient doesn't necessarily need to be influenced by mass media, right? It should be science, and it should be clinical decision making. And that is partly true, but not completely true. And I think that there's a good evidence just in the general agenda setting literature, political literature, that news coverage affects the way that we think about the world and the way we decide where problems exist. And the terms that are typically used, which I'll proffer for you, are that news media coverage helps us frame issues in a complicated tapestry of problems, pick which ones we're going to focus on. And moreover, it can have a subtle effect, or what people call as priming. So if you see something in the news, you might be more likely to regard it as a problem later than if you didn't. There's a lot of data, both clinical trial type, randomized controlled data, and then just observational data to demonstrate those kinds of effects. In the health policy domain, there are meta-analyses. This is actually from the Cochrane Collaborative, very respected reviews on various public health and biomedical issues that demonstrate that news media coverage changes the way people behave with regard, in this case, the examples that they use, to dietary things, salt and fat intake, that news has impact on how we then respond to that kind of health information. And moreover, this article from Clegg and colleagues is actually a very nice demonstration of how the number, just the pure number of articles that are critical of smoking in different geographic regions, if you look at the numbers of those articles, you see responses that indicate a decline in the rates of smoking downstream. Okay, pretty powerful public health message. Sometimes the message can be negative. And I cite this work from Japan, two sources, because it was very influential on my methods. But these articles demonstrate, I think, nicely that if a celebrity commits suicide and the newspaper propagates news of that suicide, you will see higher rates of suicide downstream in the general population, a pretty important sort of message of contagion that begins with the news media. And finally, I would be remiss if I didn't point out that many commentators and many researchers have noted that news media signal can be wrong and can lead us to bad healthcare decisions. And Colleen Berry at Hopkins has been especially influential on my work regarding this. She and Susan Bush in 2010, as one example, reviewed newspaper signal on the SSRI warning and commented and demonstrated that they felt that the news signal accentuated the controversy. That's part of the criticisms, right, that journalism often gets. Moreover, you see that in other areas too, and perhaps most dramatically, these two references, and especially this nice book by Comas, reminds us and describes how the myth about the connection between vaccines and autism has been propagated by the media as well. Okay, next slide, please. So news media matters. So my dissertation research is about trying to put this together into what I'll boil down for you as a very simple model. I'm asking the question is, can I show that drug use of a drug that's subject to an FDA warning is a function of a delayed response, a little bit of time to get people to get to the doctor and to get their prescriptions filled, to newspaper warnings per se, okay? And I do this, and I'll thank my committee member, Carlo Di Clemente, who knows about behavioral change, is an expert in behavioral change. And I originally had 8 to 10 warnings, and he said, you better carve it back to a few. So I'm focused on 4 warnings here that I look at quantitative. I'm going to tell you how I do that in a minute. But the antidepressant warning I've described to you already happened in 2003. I also described for you the diabetes medication. This is Avandia, by the way, is the trade name of this medication. Heart attacks was the concern in 2007. Smoking medication, varenicline or Chantix, suicidal ideation, aggression, neuropsychiatric sequelae. You can see why I might have been interested in that. And then finally, leukotriene inhibitor, Singulair is the common brand name of this medication, also had neuropsychiatric events. And that's a medicine for asthma, okay, so it connects me to it's a good thing I'm doing the Green and Healthy Homes project that I'm doing. Okay, so these 4 warnings are the subject of my research. Next slide, please. The methods that I use quickly are as follows. I got time series for each of these warnings. For For the first two that I described, there were actually published time series. So in papers that I was able to find in the literature, I got by-month counts in some way of use of the drug, and I used those directly for my research. For the last two warnings, there were no published time series, so I generated them myself. I got permission from DHMH to use the Medicaid data, and I generated some time series myself on that. That, if you will, is the outcome variable, use of the different drugs. The input variable came from selecting newspaper coverage by looking in databases, LexisNexis, ProCite, to name just two. But I scoured the internet resources I have available to me and identified over 3,500 potential articles that would be relevant to use of these drugs in some way based on a keyword search. And then I, along with two students, a graduate student and an undergraduate student, first selected these. So of the 3,500, we had to figure out which ones were relevant, come up with rules for that. We selected 1,000 of them, and then we coded those 1,000 items for the following information. We asked what was the orientation. Did they heighten concern about the warning, or were they just talking about the drug in general and not? Those were the two forms. It was rare that an article said the warning wasn't of concern. Then we also looked at some other basic things about the article. Was it on the front page? How long was it? What was the media type, broadcast or otherwise? Then finally, in those last three bullets, we looked at whether or not the FDA was mentioned and whether the warning was mentioned in the article. And we looked at anecdotal valence, and by that I mean if an article, for example, and this is a real example, had a lead that said a 12-year-old boy shot his grandparents when he was on Paxil, the antidepressant Paxil. That really happened. It was really reported in the news. That article had high valence, high anecdotal valence, versus an article that reported a JAMA review of EpiData on SSRI concerns. That was a low valence article, so we coded that too. And then, inspired by Gary Schweitzer, who's a journalist at the University of Minnesota, who got tired of just complaining about healthcare coverage in the news, decided to do something about it, and started this website called Health News Review, and they review newspaper coverage. I adapted his schema in order to evaluate the quality of the newspaper coverage that we were looking at, and the students that I recruited were trained to do that as well. Next slide, please. Okay, so here are some early results then from that work, okay? And I'm going to just go through. It's actually listed by warning. I'm giving you one result for each warning in a very simple statistical framework. We're looking at a 2-month lag, so I'm letting about 60 days pass before I look for a correlation with behavior, with prescription, using the prescription medication. And I'm looking at just one parameter that I actually measured in this case, and that is how many articles, what were the number of articles that increased concern about the medication? Okay. And let me just go down the line, and I'm going to interpret for you these coefficients that I got and tell you how believable I think they are at this point. Okay? And I'm going to be looking carefully at my advisor over here, who is my statistical reviewer, to see what his reactions are. So this first row is for the SSRI warnings. The interpretation of this coefficient is as follows. For each additional newspaper item that raised concern about the warning, the percent of children diagnosed by a primary care physician, and they diagnose a lot of depression in kids, okay? The percent of children diagnosed by a primary care physician who then received and filled a prescription for an antidepressant decreased by about a quarter of a percent, okay? Consistent with my hypothesis, right? The news mattered. The result in this very simple OLS framework is significant. And then just to give you a little bit more information about how many observations I had, there were 50 months of data that I had, and across those 50 months, 587 articles that were reviewed. And oh, by the way, important thing, the article counts, there was a lot more coverage about the SSRI warnings than the other ones I looked at. Tells us something about major mental illness and kids and how much news that gets versus the other problems I looked at, perhaps. Okay? So I feel pretty comfortable about that regression. Okay? With regard to the diabetes medication, what this is different units now. Okay? What this is telling us is that on average, across all of the months that I looked at, for each additional article that was expressed concern about the warning, there was a minus 2.4 per million member decline in claims for that drug, Avandia. Not a significant finding in this case, but I actually don't, it turns out my time series that's published has a lot fewer observations. I hope to fill that gap with the Medicaid data. So we'll see if that holds up, okay? That small decline correlated to news coverage. So that one's equivocal right now. Chantix, the smoking medication, a decline. The way to interpret this came from the Medicaid data now, is that on average, for each additional news item that increased concern about the drug, there was a decline of 13 filled prescriptions in the Maryland Medicaid program for that drug. By the way, there's about 600 prescriptions per month during the time period for Chantix, because other drugs are used, substitutes for that drug. So that's about a 2% decline. It is significant finding in this simple framework, and it's based on a fairly substantial number of observations. I feel fairly comfortable with it and encouraged by it. Finally, with regard to the asthma medication, again from the Medicaid data, there was a 175 prescription fill decline correlated to each additional article that raised concern. That is only a statistical trend, and moreover, I want to tell you that I made this model a little more complicated, not much, but a little more. I put in a seasonal adjuster because in spring there are way more asthma prescriptions than there are in other seasons, and that was borne out by the model. So we'll see what happens with that. So next slide, please. So I think I have very tacit, simple confirmation of the models that I'm looking at. There's much work to be done this year to finish this up. And it starts with me looking at the lag structures more carefully. Right now, as I said, I was looking only at a 2-month lag. What about a 3-month lag, et cetera? Earlier month lags, shorter month lags didn't seem to be impactful, but I need to do this in a rational way. And I also need to think about autocorrelation, which is a somewhat fancy way of saying that I need to think about the fact that an observation at time t plus 1 is just by virtue of that juxtaposition going to be correlated to observation t, and that impacts the way you model things statistically. So that needs to be addressed, and I plan to do that. I also need to address diminishing and plateauing effects that are likely to be involved here. If anybody is an expert and interested in this, I would welcome your counsel on that. But simply stated, I think that with time, the warning to news correlation will perhaps diminish, but also I expect some plateauing. I don't expect things to sort of return to normal if this is really a true warning that people should be attending to with time. Okay? I'm going to be testing other variables, front page placement, for example, anecdotal valence, the other variables that I described, and I also need to consider the fact that this is a correlative study. It's not a clinical trial, so causation does not definitively determine causality. Correlation does not determine causality, but there are some methods, and Grazier causality being one of them, to at least demonstrate temporality, that if A causes B, then A should come before B, as opposed to the other way around. And that could be the case here with this kind of research, right? The newspaper coverage could be reflecting what's happening at the doctor's office. My hypothesis, however, is the other way around. There are many limitations to this work. I'm looking at a very narrow aspect of healthcare communication, newspaper coverage. I'm not looking at public service announcements, physician letters, direct-to-consumer advertising. These are all germane, but I'm narrowing my focus on these, and so potentially I have some admitted variable biases that at least I have to address theoretically. And I've selected only 4 of many warnings. There are 100+ warnings that the FDA issue every year. So I'm just starting with some conveniently picked case studies, if you will. Next slide, please. So finally, the policy implications of this, hopefully I persuaded you of that, right? This is a health communications, health literacy education kind of problem. You know, the FDA actually has a risk communication advisory committee, a very active committee that doesn't just deal with drugs. They deal with food, cosmetics, devices, you know, MRI machines, et cetera, and they have an ongoing responsibility to advise the FDA about how to convey to people what their risks are when they use these things. It's actually gargantuan responsibility. Ongoing responsibility changes with changing technology. I hope my research can provide some information about how that's worked in the past and adapt it to future problems that the FDA will certainly face. And moreover, I hope that it might help optimize reporting, because news reporting can get it wrong, right? The yellow cake in Niger gets us into the Iraq War, right? Because the New York Times got it wrong, okay? It's not being hyperbolic to say that journalism is arguably one of the pillars of our democracy. In addition to corporate power and government power, religious power, you've got that other estate, the newspaper objective reporting, ideally, okay? So I hope that my research will inform on that. Next slide, please. Next slide there, thanks. So this is my last slide, and it gives me a chance here to thank a couple of people and then to also talk for a minute about Judy. And these 3 pictures are of Judy, and this is Judy's sister. I'm going to talk about her in a minute. But let me first thank a couple of other people. First, David Salkever for being a fine colleague, a scholar and a gentleman. Really appreciate all the work and look forward to more work and look forward to getting my degree done too. My dad is here, Bruce, and my mom is on the camera there somewhere. And I can tell you, and this is mental health content, okay? I won the lottery with regard to getting parents, and you know, I have curious, energetic, loving parents, and I really feel quite fortunate for that. So thanks, Dad, for coming. Thanks, Mom, for being on the camera. And at the reception, make sure you ask Bruce about his golf game. Tell him to work on his putting a little more. He doesn't hit it so far now at age 83, so he's got to work on the short game. And also ask him about how he was one of the first elected officials in this country to fight big tobacco and try to get smoking out of public places. Ask him about that, okay? And so I won the lottery with regard to parents. I also won the lottery with regard to my spouse, but I actually take some credit for making a good choice in that regard. So Michelle Mazzocco is here, and she's been a wonderful support for this, so thank you, honey, for that. Finally, let me turn to Judy. She was, I was just kind of really getting to work with her and getting to know her well when she passed. But I took a course. She lectured for David, so I've seen her teach and had lots of conversations with her about a variety of topics and worked on these two projects that I described to you. So I do feel a real connection to her. I do miss her. Certainly a life cut short, but and perhaps is so nicely demonstrated by the picture above, a life well lived. And she had impact on me and a lot of other people in this room, both academically and personally. And when I got this award, this is Mary Cohn. She's Judy's sister, and she is a music professor at University of Iowa. And she sent me a nice note, and she said, my sister inspired me to get my PhD and inspires me still today. And one of the projects that Mary works on is actually something I think Judy would have really appreciated and perhaps would have even wanted to evaluate, and it's bringing the choral arts to incarcerated individuals in Iowa. So what could be a more poignant kind of mental health intervention, really, quite frankly. So Judy inspired lots of people, including me, and I am grateful for that and motivated by that. And thank you all for listening and being part of this.
If anybody has any particular questions that you want to follow up on with Michael, or otherwise I'm sure you can grab him. He'll be heading straight for the bar. Feel free to pursue that. Turns out we do have a little something in here for Michael. We're going to save it for you though until you finish. No, I'm just kidding. It says UMBC School of Public Policy Judith Shinogle Award for Health Policy Research, presented to Michael Abrams 2015. Congratulations, Judith.
Thank you.
My pleasure.
Stephen is here. Do you want to recognize him? Stephen is here. Do you want to recognize him?
Oh,
Thank you,
oh
Mike.
yes. We have one other eminent former awardee of the Shinogle Fund, named Stephen Johnston, who is an active researcher at Proven Analytics and progressing as well in his academic studies, and probably is actually even involved in even more projects besides his thesis than Michael, but is I'm sure we'll see some very interesting and valuable products from him continuing on into the future. So thank you for joining us.
Do you want to take questions?
Sure.
Okay. Any questions? Just fire them up to Mike. You were so persuasive.
Can I ask you one?
Go ahead.
That's okay. I mean, I've got a couple I'll ask afterwards. One of the things that I wanted to ask about, you kind of was on one of your slides, showed the increase in, I think it was like I don't know what the term is, but the increase in mental health diagnoses for boys and girls,
Right.
and how they
Right.
dropped after.
And can you go back to that slide?
Yeah.
Keep
I
going.
think this is really interesting. To
Yeah,
me,
sure thing. That's a good publication. Look, right there, that's it.
That's the one. What is that? The major depressive disorders. And so it looks like the observed rates really dropped, but what I thought was really interesting is a really big increase in the trend rate of diagnoses, right? I mean, it's like 100% for, what is that, boys and 100% for girls. What's driving that?
Yeah, so there was expanding use up until that warning was issued. There was greater comfort among clinicians to use these medications in kids, and it was big psychiatry. I'm thinking Joe Biederman at Harvard University was promoting the use of antipsychotics even at that time in kids. That's somewhat controversial too, but you can see that those trend lines are going up, right? Until the warning is issued. So there was increasing comfort for using drugs for what was essentially an off-label indication, right? It wasn't approved in kids, but clinicians were getting more and more comfortable in using it in kids. And that was, the reality of the status quo at the time. Still pretty prevalent use. I mean, there's lots of use of these drugs in kids. So.
I think my question was just a little bit different, though. It
Okay.
looks like the rate of disorders is increasing dramatically during the time series. And so is it something organic that is causing more young people to have depressive disorders, or is it an expansion of the clinical criteria to be diagnosed?
Right. So is it that there was something really leading to greater depression, or is it that practitioners are more comfortable with assigning that label to children? And I think that the research is that both is happening. So Well, actually I should phrase it this way. The research is that in some cases the diagnostic label is inappropriate and is being used more liberally than it should be. And in other cases, for the first time, clinicians are acknowledging pathology that was there that they didn't acknowledge previously. So both are happening, and I think that that's supported by.
Let me just ask quickly, because I'm a little confused. Is that
Sure.
incidence or prevalence?
This,
Is that new diagnoses?
yeah, this is new diagnoses.
That's what I thought, yeah.
Yep, this is new diagnoses of major depression, and the rates are per 1,000 individuals. So we're talking about, you know, not huge numbers, less than 1%, because 5 per 1,000 is your max, is your peak there. But you're observing correctly that things were on an upward trend until the warning was issued in 2004, and that seems to have at least partially disrupted that trend.
And more than a question, is maybe one important suggestion, because you were talking about different warnings and you pick only 4 of them. I'm sure that you have a lot of them in mind. But one interesting thing from the substance abuse that I'm working with is about overdose deaths. And we know the big problem that we have right now. And part of that is in the famous slide that always we saw, that the prescription drugs that the people are using is 4 times in a very short time. And they are completely, it's a high correlation with the overdose deaths. And it will be very interesting to look in the same way in terms of the warnings for the overdose, because I can see something very beneficial for the future. And bottom line, we know that the people are using all of these medications, pain medications, like they are candies. I'm sorry to say that, but the people don't know the influence, the big influence about that. And it will be some suggestion or recommendation. You can see that would be great.
Right. Yeah, use of opioid replacement therapies and pain analgesics and stuff is actually, as you know from the project we're working on together, a big issue right now, and overdose deaths related to that, and it seems to be related to people shifting over to heroin in this region, which is an added problem. So certainly there's opportunities to do this kind of time interruption. I don't know whether the FDA has issued any particular warnings on fentanyl or anything like that. It's plausible that they may have, but the kind of time interruption look that I'm doing could be applied to other things besides, in this case, the FDA warning is what I used as an initial starting point for my time series. That's essentially how I
Exactly. Or another look for the post-marketing survey.
Yeah.
Just a quick, so have you looked also at whether the warnings have been redone? So for Chantix, for example, there's just a new warning that came out about Chantix and alcohol.
Right.
So does that affect your
Yeah. Well, and even the SSRI warning, there were like sort of 5 iterations of it. So 3 of the warnings I've looked at are black box warnings. And so that's pretty high level, and they're still in existence. But there could have been added additions to it. And one of the analyses I do will be just a time interruption for when the warning was issued. Part of what I'm counting on, and this is a little bit of a risk, but part of what I'm counting on is that if a new warning is issued, it might lead to a signal, and I've seen that in the news media, so that actually contributes to that signal and is sort of being accounted for there. But what you're talking about is sort of a separate warning, and currently the models don't really account for it. It's sort of a limitation to the way that I've set things up at this point. So my discussion, at least I'll have to account for that and talk about whether or not I think it really is sort of a point in time kind of situation, which is not the real world, right? Or to what extent other things were happening that would have influenced consumption of the drug as well.
Thanks.
Yeah.
take one more question.
So when you're counting the media coverage, are you including advertisements for the drug?
No, this is purely objective news coverage. In fact, we looked at opinion pieces. There aren't that many opinion pieces, but objective, presumably hard news sourcing is what we're quantifying here.
Mike, thank you very much. So let's all wander back toward the food and the libations and enjoy some conversation. And I'm sure Mike will be more than happy to converse with whomever would like to converse with him about his project. Thank you.
Thank you.